Dr. Munnawar Shah, and the topic is biologics in rotator cuff pathologies.
Sports related, but I think we have already started the biologics part of it, is that correct? Yeah, because tears, degenerative tears are only in the elderly, so can't be athletes unless most Americans at the age of 60 are still very active. Anyway. Okay, so it is a common phenomenon, rotator cuffs. And the older you go, the worse it becomes, and the more chance for you to tear it by doing little excessive exercises. And mostly people above 80 are definitely going to have a tear. Okay, the older you are, the massive the tear, and it'll be very difficult to compensate for it. So before we go further, I'm just going to quickly say the crux of the talk is that there is no role of biologics. It may or may not help, but evidence has not proved it. Okay, so I can continue the lecture, or we can just call it a quits and say, yeah, there is no role. So these are the bad prognostic features. The older you are, the massive the tear, the more the retraction, the more fatty infiltration there is, it will be very poor to control it. However, lately, well, not lately, now it's more than when I started medicine, it was going on. It's the double row repairs have made some difference rather than what was done before. So maybe there is a hope. And the key is to attach the tendon to bone. And the re-tear is never at the where you repair it, but further forwards. The scar does not develop as it should, and it doesn't heal because it's cartilage and fibrocartilage. Therefore, it doesn't behave or follow any plan. So the one on the left side, the pinky one, the really pink one, shows bone tendon attachment with mature fibrocartilage and undifferentiated fibrocartilage. The one on the other side, the totally pinkish one, or whatever color you want to call it, the repair is very haphazard. It doesn't go to bone and attach itself, and therefore there is a very high risk of re-tears. Okay, and maybe you can do biologic augmentation. Okay, but that's something that you have to still wait for the results because the jury's out on it. Okay, and this is one form of biological augmentation where a skin of porcine is actually used as a jacket to graft the repair that you've done. Okay, again, there are various papers out there with good or poor success in this particular method. In my hands, it didn't work. I did a few of them, but it didn't work. There are no articles found, which I started at my talk, which says that PRP works in the shoulder, especially in cuff tears. A lot of surgeons swear by it, and they say, I've used it, and it's got great results in my practice. However, if you can't publish it, then it's not evidence, and therefore other people cannot follow your lead if you just tell them that I've done it and it's great. Okay. There is a role of PRP maybe in slap tears and biceps tendinitis where there is no tear. In cuff tendinopathy, if you have a partial thickness rotator cuff tear, then it will stop re-tears, but that's all. And biologics are coming up and fast every day. Every day. There are blood-derived, there are cell-based, and then there are grafts. Okay, so where is the problem when you do PRP? And I think it's the WBC. And WBC can go either way, depending on the concentration of WBC in your injection that you do or in the preparation you make. It may be good or bad. Okay, and it does weaken the tendon if you have too much WBC in your preparation. So this is a very, very basic study, and they looked at PRP8s, and it says that they could heal pastor repairs, but there are not many pastor repairs that you need to get it. You just repair it, tidy it up, and maybe or maybe not put PRP at the end of it. Like I said, the PRP concentration depends on the WBCs you put in, and it will go either way. There is a zone of weakness after the repair. Okay, so there was a anecdotal quote that everybody uses in most papers that people talk in lectures, is that they compared platelet plasma, rich plasma versus cortisone injection in non-surgical management of shoulder pain. And the graph shows the red is the control and the blue is the injection, and you can see there's no difference. You can kid yourself and say it works, but it doesn't. And these are the pain scores, and you can see the ones that got injected are the blue, and the red ones are the ones that had nothing. They were the control group. And again, there is no worth talking about difference. So they can be used, like I said, but slap rotator cuff repairs and stabilizations. Again, how this is a rotator cuff tear, and we inject it into where the tear was. Again, they have now changed that ideology, and they say that instead of putting it where the repair is, you should inject where the bone tendon attachment is. And these are all the studies in the last so many years, and again, you can see there is no level 1 evidence to support PRP working in the shoulder. Okay, so it does not provide significantly better scores, and isolated results do show that it may or may not work, but that's people's individual opinions rather than evidence-based. There is a subgroup analysis. After all these people were reviewed and sorted out, they found out that there is a catch. The subgroup of people who have a PRP, they show less tears or re-tears, which may be of benefit in the future, that if you have a tear and you inject them at the bone tendon interface, then they may not tear again as you would see them normally when you repair the cuffs. Okay, and that's what it is coming out from evidence, that instead of repairing it and injecting it at the repair site, we should repair it and then inject it at the bone tendon interface, or not inject them, because there are other evidence which people show that you can inject the whole PRP into the shoulder and it will work. Okay. Most evidence suggests that routine PRP use at time of arthroscopic rotator cuff surgery does not universally improve re-tear rates or effective clinical outcomes. It's very doom and gloom, isn't it? But that's the topic it is. The overall consensus is that it may be advantageous for small and medium tears to prevent re-tears. And a number of randomized control studies confirm what we've just said, very little benefit. So for us to use PRP in cuff, we have to show that it's beneficial, evidence is there, and it's cost effective. Okay? A new thing has now come out. I mean, we thought that cigarette smoking was bad and we should not use it, but now the leaf of the tobacco has got the same structure as the cartilage of the rotator cuff. So they are now telling us with evidence-based that if you take PRP, this tendo-ACP, which is PRP with the concentrate of the tobacco leaf, may be better. And they have shown why, because the structure matches the cuff structure. And if you have a tear, you've repaired it and you inject it, and the vision. Okay? So there is, again, not very conclusive evidence, but they are promoting, the company that's promoting is providing evidence, and again, you have to be very cautious to take that. So this is one of my patients where we've repaired it, and I have injected it where the repair is. Again, if I had known earlier, I would have injected where the bone tendon interface was. Okay, so there is a quicker appearance of the mature cartilage. There is very little or less granulation tissue when you do the tendo-ACP, and the inflammatory cells and the mononuclear cells also go down. Okay, so finally, this is the third trick. It's called monocytes. And apparently monocytes work by taking the pain away, but it doesn't help in healing. Okay, so we do that. I mean, has anybody seen the use of monocytes? Have you? Yeah. So basically, you take blood, and you have a bag that's up there, and it is gravity controlled, and the blood goes through it, and it filters through it, and whatever's left behind is monocytes. Again, it takes pain away. It doesn't do anything else. If you can see the X-ray, it's got a beaked acromion, and it doesn't look like it's arthritic, but I have used it. I have a good enough experience for it, and pain does get better, but again, the tendon doesn't heal, so there is no other role. Okay? Thank you. The long and short of it is that you need to justify the cost. It costs about, in our part of the world, £750 per injection to do for a cuff repair. And if you're not repairing, or the cuff is not being repaired, then you cannot justify using £750 for something that doesn't work. Sorry. Acha, photo. मुझे भी मिलेगा कि नहीं?